really fast. She's a OB-GYN doctor here with us at Northwest Perm, and one of our real experts in perimenopause and menopause, and also how to best approach libido and sexuality concerns in our patients. She's helped develop and teach our sexuality class, which she'll talk more about. And we're just really happy to have her here today. And I would say I know there's probably going to be lots of questions, but let's put them in the chat and then we'll see which ones we can get to after the talk, if that sounds okay.
Thanks, Toby. I basically adapted this from the sexuality class because I'm assuming people don't know a lot. I will try to focus on the meds because I know you guys have interest in that, but I will also try to cover just basics of sexuality because I didn't, for me, it was all new. So if we can go from there, and I think I can take over the slides. I don't know how to do that other than share my own slide screen.
Yeah, if you'd like, feel free to click on the take control button that you see above the slides. If not, I'm happy to move them myself as well.
I don't see the slides. Oh, you mean just the big slide that's looking at me? Take control. Okay.
Yes. Yeah.
All right. There we go. Okay. Okay. Oh, wow. These are official. Okay. So this is basically basics of women's health. And I'm Joy Pretcher. I'm one of the docs at Interstate. I know a lot of you. Thanks for giving your time and interest to this because I know your patients probably want to talk about it as much as our patients want to talk about it because we have the same patients. The objectives are that the assumption that you guys know nothing about this, which is probably very much untrue, and provide a basic review about sexual function, dysfunction, and resources. The asides is that there's limitations where data isn't inclusive and things may not feel inclusive. Most of the data we have is about cis-hetero relationships. What I've learned the most, if anybody's interested in this particularly, is attending ISWISH, which is the International Study for this Society for the Study of Women's Sexual Health. And they have a meeting every fall in Scottsdale. And the Menopause Society meeting also has a huge sexual component. They do a whole day of sexual function. And so I've stolen most of these slides from them. There are some aha slides that I think struck me as really important and helpful, and I'll try to give you a heads up about those. This talk is basically 4 parts: anatomy, sexual response cycle, types of female sexual dysfunction, and therapies, and then resources and discussion if there's time. So my goal for you is to review lots of content, hope you find it interesting, and to arm you with great context for discussion and management where appropriate, and have you be a resource for your patients. Other than moving the slides forward by clicking, is there any other function? I don't think so. I just have to keep clicking on them. Sorry. It might be a little clunky. So the problem, sex is difficult to talk about by many of us. I got interested in this topic because I had a patient who asked me, her chief complaint at the end of the day, literally, the little exam notes for your appointment said, "I do not desire my husband." And I had no idea what that would look like or what that looks like. And I had to make the assumption that he just wasn't desirable, which is not at all how I would handle that conversation today. But so again, these are awkward conversations. We don't have a context for it. We don't learn a lot about it. And patients want to talk about it. It's incredibly important to them. Sexual distress is actually pretty common, with 43% of American report experiencing sexual problems, with 12% considering it so bothersome as it causes distress. A lot of people think that this has to do mostly with late life, but it actually spans all parts of the reproductive lifespan. It does peak in midlife, but no one's immune. What's so great about sex? There are all these tremendous health benefits of sex. Can lead to a longer life, protect against heart disease and possibly stroke, can bolster our immune system, help sleep, burn calories and fat, help with chronic pain, migraines, protect against depression, reduces stress and improves self-esteem, and it's really stimulates feelings of affection and intimacy for partnered sex. This is an aha slide coming up. So this is what's so great about sex, right? Sex actually adds 15 to 20% additional value to a relationship. That's amazing, right? What about when sex is not great? It depletes a relationship up to 70%. So this is when your patients the little tears start to water in her eyes because she is so feeling horrible and shame and guilt about how it's impacting her relationship when there's sexual dysfunction. So this affects people really strongly when things are not going well. Basic assumptions about sexuality. It's an important, positive, life-affirming force. It's going to be influenced by many factors, and it's going to change throughout life events, lengths of relationship, aging, and many, many, many other things as you're going to see. And it may not feel like a safe place for many people. Sexual trauma is incredibly common, and this conversation can be really, really touchy for a lot of our patients as well. I just talk about anatomy. You guys are all going to know anatomy, but I'll review it really briefly. Anatomy is having a moment. This is from the Lady Garden Foundation. Lady Garden is a colloquial slang term for female genitalia in the UK, and this is a nonprofit whose aim is to educate women about their anatomy. Their ultimate goal is cancer prevention and awareness of gynecological cancers. There's also a vagina museum, also in the UK. This is from a local cupcake bakery. Vulva art is everywhere. So here's our basic anatomy that all our patients learn about in health class. This is basically all they know. For the most part, people often can't tell their vulva from their vagina. So I always want to talk about, the different parts of anatomy for people so that they can describe, especially with pertains to pain, because pain causes a lot of sexual dysfunction. So I go over, anatomy. I go over vascular supply because vascular disease can impact sexual function because how it keeps our organs healthy. The pelvic floor muscles, are taking on a huge role now, very well recognized in terms of pelvic pain. They think 50% of pelvic pain in women is actually attributable to somatic dysfunction, which is keeping our pelvic floor physical therapists incredibly busy. It's very easy to look for pelvic floor pain. I don't know if how many of you might be trained to do that, but if you're not, I would definitely look into it because so many of your patients have secondary pelvic pain, usually from either back pain, chronic back pain that's gone not well managed, or injuries. Limb length discrepancy can cause pelvic pain and other downstream sequelae. And then the nerves, obviously, and we see a lot of patients who have neuropathy. This is the true anatomy of the clitoris. This is from a German sculptor, Sophia Wallace, and as more recent cadaveric dissections in the early 2000s actually led to much, much more detailed anatomy of the clitoris, which has made a lot of us question labiaplasty surgeries and other things that might injure this magnificent organ. This next slide is not meant to be offensive, but it is a classic. I stole it from Audrey Curtis. Differences between male sexual dysfunction and female sexual dysfunction. Male sexual dysfunction is not this simple, but it's just a silly slide that talks about the complexities of female sexual dysfunction with lots and lots of knobs and buttons and levers. So these are drugs approved by our FDA for treatment of sexual dysfunction for men. There are 26, and for women, there are 2. This is the human sexual response. That's the classic from the 1960s from Masters and Johnson about how what the sexual response cycle is, and it starts with desire, and then is followed by arousal. Desire is just spontaneous want of sex and spontaneous interest in sex in the absence of arousal. Arousal is the physical response to wanting sex, which is erections and vasoconstriction and lubrication, all of those tissue responses that we see. And then you have sex, you orgasm, and there's resolution. But in this model, desire precedes arousal. Turns out that this is how 75% of men experience sexual response. As of the early 2000s, there is a model of sexual response that seems to be most common in women. This is from Rosemary Bassan, who's a sex researcher in Canada. And this is the circular model. This is another aha moment slide. So this circular response is based on a state of not spontaneous desire, but sexual neutrality, meaning sex is really not present in the milieu unless there is a certain response to sexual stimuli. So let's take a step back. So no interest or desire or anything, just neutrality. And then in the presence of a stimuli or a cue, say, an erotic scene in a movie or a book or a partner touching someone in a certain way, that would be considered a sexual stimuli, there is a fork in the road. The fork in the road is, do you respond to that stimuli in a positive way, or do you respond to that stimuli in a negative way? And it turns out, if you respond in a positive way, you get aroused, and then desire follows arousal. You want sex after you're aroused. And that is the circular model that the majority of women tend to experience sexual response. This and this are two different things, and you can imagine that there could be conflict if one partner is expecting someone to be just having spontaneous desire all the time and thinking about sex and just being plain. I don't like the word horny, but horny kind of describes spontaneous desire to me, versus this, and how there could be conflict in that. And then most of the research in the field of women's sexual response and function has to do with that fork in the road. What's going to determine whether that response is inhibitory or excitatory? So turns out that there's a gazillion things that impact that fork in the road and which direction people go. And that has to do with psychology, interpersonal, sociocultural, and biology. As we all know, many, many of these things influence our our well-being in many, many ways, including our sexual well-being. So you just march along. This is the sexual tipping point. It's sort of a nice model that I use to kind of describe and show all of the things that impact sexual response. And the excitatory and the inhibitory, if you've ever read Emily Nagoski, she talks about the gas and the brakes, and she does just a really beautiful job of describing this. So in essence, normal sexual response is a dynamic between excitatory and inhibitory factors, gas and brakes. And then what is dysfunction? Dysfunction are various conditions that are characterized by reported personal distress in one or more of the following areas: desire, arousal, orgasm, or pain. And I was going to try to cover all of those. I know you guys are want to talk about desire probably the most, but I'm going to cover everything because they really are interconnected. And a lot of people will present saying that they have no desire, they have no libido, they have no drive. And really, there's actually many, many other things going on that's just the tip of the iceberg. And if we're just looking at this desire, and it's really a downstream effect of other things, we're missing the boat and not helping our patients. So the DSM-5 categories for female sexual dysfunction include female sexual interest arousal disorder, which combines hypoactive sexual desire disorder and female sexual arousal disorder combined into one. Female orgasmic disorder, genitopelvic pain penetration disorder, which I think gynecologists are, and you guys probably too, are most adept at treating. Substance medication-induced sexual dysfunction. As you know, there's always this other pile called other in medicine that we all see. So this is one of my favorite slides, the next couple of slides. These are common etiologies and risk factors for female dysfunction. This is probably your morning in the office. Depression, anxiety, breast cancer, hysterectomies, diabetes, sexual abuse, relationship discord, stress, partner sexual dysfunction, negative sexual attitudes. This is everybody. These all impact our sexual function. Medical conditions, again, this is a really great slide. I hope you can see it. It's from the Mayo Clinic, and it specifically talks about the medical condition, how it impacts desire, arousal, orgasm, and pain. The big ones tend to be depression, anxiety, hypothyroidism, and arthritis. But as you can see, many, many conditions impact So this is where you guys come in as well, since you are helping manage a lot of these symptoms. This is from the PRESIDE study. And again, you see the big players: arthritis, anxiety, thyroid, bowel diseases, and urinary incontinence. There are things that help, just like help with improved sexual desire, activity, and satisfaction. And those include the Mediterranean diet. I don't think there's anything the Mediterranean diet can't do. Exercise, resilience, normal BMI, social support, and social engagement. These are all pro-sex, as you'd imagine. They're pro-health and pro quality of life. So these are really key, and these are the things I think that our organization strives to impart to people. I'm going to talk about the disorders of arousal and desire. Again, these are the things that patients bring up, but oftentimes there's really other roots going on that it's not just desire. You don't desire sex if sex is painful. So again, lots of other things, and it's easy to get overwhelmed when someone just says they don't desire their husband. So the word libido, I have a little bit of a problem with, but desire versus arousal and the definitions. Desire is spontaneous interest, like we talked about, and then arousal is responsive interest. So the linear model is desire precedes arousal, precedes orgasm. 75% of men have this response cycle. Women tend to, for the majority, start in a state of sexual neutrality. And then if they are open to responding to sexual cues, will have arousal and desire sex. So desire tends to come after arousal for most women. Lack of spontaneous desire is not necessarily considered dysfunction, especially since it's physiologic. I think as someone who takes care of women, and you all may notice this as well, women, we pathologize a lot of things that for women are actually normal, and women bear the brunt of this. And this comes down to this sexual response, as well as, I think, achieving orgasm through the different pathways of that, and the expectations that they have based on what they see and read and what's presented. I find it hard to pathologize things that are normal physiology for people. But I asked at one of the Ishwish conferences, the experts, whether this needs to be treated. And they kind of hemmed and hawed and said, well, if it causes them distress, it should be treated. So there you have it. But why are we allowing women to feel distress over something that's normal physiology? That's my own personal beef. But again, we're taking care of patients that have other priorities. So I do always want to talk about that inherent bias. So again, here's the sexual tipping point. So what are the causes of interest in arousal disorders? These naturally change throughout your life. When, the circular model tends to happen in women who have had, who are changes with aging, with the duration of relationships. You may have had, your patient may have had the linear model when they were younger or early in their relationship, and then settled into the circular model as time went on. But these naturally change throughout life. They change in relationship to modifiable factors and partner factors, changes in sleep patterns. I can personally attest to the downstream negative effects of poor quality sleep and how it impacts every aspect of being. And you guys know all of the different health systems that it impacts. It also impacts sexual function. If people have to choose between sleep and sex, they may very well choose sleep. Stress, privacy. If your 4-year-old's in bed with you, that's not really sex friendly. If your in-laws are in the room next door, that also may be an issue. Changes in body image, shape, weight, incontinence, prolapse, where I talked about pregnancy, breastfeeding, sedentary lifestyle, alcohol and substance use, relationship factors. Oftentimes these get pushed to the side, and they maybe have a significant root in the problem. Upbringing, there's a tremendous amount of data about the negative impact of conservative upbringings sex negative households have on sexual function later in life. So highly conservative religious households tend to create more issues with sexual function. If it's a new onset, is there an undiagnosed or subclinical condition? Is it a medication side effect? The SSRIs are commonly associated with arousal impairment. The treatment for sexual desire and arousal disorders includes psychological, medical, and hormonal treatments. And so I'm going to talk about those in a little bit more detail because I know you guys are interested. I think for desire disorders, personally, I think that unless there's an obvious thing going on, I think sex therapists are going to be first line for this. I don't know if you guys know how to take a sexual history with confidence. I know that I don't, and I can't, and I'm not. I could pretend to, and oftentimes you will kind of get there, but not without an hour of an appointment time of trying to figure out what's going on. So I think that's where those come in. I think we're going to be much more adept at these physical factors like pain. So psychological, these include sexual skills training, cognitive behavioral therapy with or without medication. Mindfulness-based therapy is huge for sexual function. It increases attention to sexual cues, awareness of body and attention to present versus past future sensations, reduces judgment. And then couples therapy, we all know, the concept of vacation sex tends to be probably a function of novelty and mindfulness because no one has their garbage around them when they're on vacation. So I think that that's an easy one. Oftentimes patients will acknowledge that they have great sex when they're on vacation, and there you have your answer, is situational, and there's hope for those people. Sex therapy. So this is cognitive behavioral therapy using evidence-based interventions for sexual dysfunction. Reframes negative cognitions and provides tools to reduce distracting thoughts, offers insight and understanding to the etiology of the problem, can alter maladaptive behaviors, improve communications between partners, and then usually it takes about 5 to 20 sessions, including between session homework. These, I don't know if anyone has ever met a sex therapist, they are unbelievably just fascinating people to talk to, really interesting. Their education involves like really cool things like kink immersion. They have to do something like, I think, 72 hours of kink immersion so that they don't act shocked when someone brings up whatever kind of sex they're into. Just like really, really interesting people. This is all they do. So I do think they're a really good resource. They do not take insurance. This isn't a Kaiser thing. People are always complaining Kaiser doesn't cover this. These people don't take insurance. They are private pay, and they are worth every penny for people who have been struggling for 10 years of a relationship. So I do encourage patients to start with the experts. Medical therapies for desire and arousal disorders. Okay. So the chemicals in the brain that impact excitation that are pro-sex are dopamine, norepinephrine, oxytocin, and melanocortin. The inhibitors are serotonin, opioids, and endocannabinoids. Obviously the pharmaceuticals are looking for things that increase the excitation pathways and decrease things that have the inhibitory pathways. So we've got flibanserin and bremelanotide are the two FDA-approved medications for desire disorders. And so I'm going to get into those in a second. None of the pharmaceuticals that we have are particularly great or outstanding. So I always want to say that as well. So flibanserin is Addy. It is a pill that's taken daily. It resulted in 0.4 to 1.0 additional SSEs, which are sexually satisfying events per month from an average baseline of 2 to 3 per month with daily use. So not huge. It causes dizziness and drug interactions. There was a black label warning with alcohol use, and then it turned out that there was worse alcohol problems with Viagra, and there was no black box warning for Viagra. So now it's just the warning of not to use alcohol within 2 hours of using Addy. Sildenafil citrate is Viagra. There's really no role for Viagra for desire disorders, but maybe in medication-related orgasmic disorders. Bremelanotide is Vyleesi. Comes in an auto-injector. It's used up to 8 times a month. Use it 45 minutes before anticipating having your sexually satisfying event. There is not a significant difference in the number of sexually satisfying events, and it can cause nausea, which is not insignificant. Up to 40% of people are going to have nausea. That will improve with continued use, but that is impressive. Can cause hyperpigmentation at the injection site, which can be permanent, and some cardiovascular risk. Bupropion is Wellbutrin, we all know. It's off-label for this, but it's considered first choice. If there is distress, and it increases the desire for desire, reduces anxiety, and there's excellent long-term safety data for Wellbutrin. So if a patient really feels like they want to try something, Wellbutrin is a really great first line thing to try. And then there may be some topical treatments in the pipeline. So enhancements, lubricants, moisturizers, erotica, devices, and tools. Actually, vibrators were classified by the FDA as an OBGYN therapeutic device for the treatment of sexual dysfunction. 50% of households have these. There's lots and lots of different varieties to them. Your HSA will cover them. Hormonal treatments, we probably are familiar with these: local vaginal estrogens, hormone replacement therapy, which can help with symptoms that might be impacting well-being and health. Testosterone gel, I'm going to talk about. This is for postmenopausal, largely because it's class X for pregnancy. It is not FDA approved. It has side effects. It's meant for short-term use, and we don't have long-term studies for safety and efficacy. My colleague Jean DeHaan uses, high doses of testosterone, and many of you guys probably do as well for our gender pathways patients. But it's a different population, and these experts tend to be a lot more conservative because we're talking about postmenopausal people who have different metabolism and health pre-existing conditions in general, much more so. So testosterone results in a small increase in sexually satisfying events per 4 weeks. So an increase of 1.9 versus 0.9 events over a baseline of approximately 3 events. There was, the New York Times has done a series, I think it was about 6 months ago, a series of women's sexual function, and they did a testosterone article, and there was the comment was, it's not whammo blammo, and there is nothing that seems to be whammo blammo for this problem, unfortunately. So in brief, testosterone modulates sexual behavior. Serum testosterone levels do not correlate with HSDD baseline. People want their testosterone checked to prove that it's low. You can't do that. Women with PCOS who have elevated androgens do not have better desire than women with lower. I do find it helpful to check a baseline because sometimes I'll find at baseline someone's already in the therapeutic range, and that's going to make management very hard, or they're often elevated. So that kind of takes that testosterone off the table for me. But it improves desire. And so it's recommended for postmenopausal women with HSDD not related to modifiable factors. We've seen how many modifiable factors that there might be. So this is really not first line. You want to kind of go through all the other things. It can improve desire, reduce distress, increase the frequency of SSEs, arousal, orgasm, frequency, pleasure, responsiveness, and self-image. A lot of patients are requesting testosterone for like energy and muscle mass and motivational things. And I think it's being used in other countries for other indications that would be super off label here, but I have had patients asking about it. It is not FDA approved except in Australia. Compounded testosterone is not approved or recommended by any experts. That the dose is 1/10 of the male dose, and how we do that is we have an order set that I'll tell you about in a second. You really don't want to give this to anyone who has any contraindications to estrogen. So I'm talking about the breast cancer crowd, the clot crowd, the cardiac crowd. The surveillance is intense. It involves serial CBCs, lipids, and LFTs. You want the testosterone levels to stay within the upper limit of the physiologic premenopausal range. So between 27 and 40 is what I usually say. It requires annual exams to look for symptoms and exam findings that might suggest hyperandrogenism, annual mammograms, and then precautions. You can have permanent changes in the voice, which can be very dramatic, clitomegaly, hirsutism, etc. This is from Up to Date. You may be familiar with this particular paragraph. I review it with everybody. The frustrating thing is when patients are not good candidates. If someone's like super healthy, this is a really obvious thing that might help them. Certainly can consider it, but a lot of the patients I'm getting are not great candidates for it. They have a lot of other things going on, and it's same thing with HRT. Hormone therapies, you've got the patients who are the poorest candidates for it wanting it the most, and it's hard to have that conversation. But for this from Up to Date, they rarely use testosterone. They'll prescribe it when greatly desired by a peri or postmenopausal patient. We've had some conversations with pharmacy about this. If someone's in late perimenopause and there's no chance of pregnancy, you can offer them this. But with again, it's class X drug for pregnancy, so that's been the hugest concern. Low libido associated with distress, who has no contraindications to testosterone therapy or identifiable etiology for sexual dysfunction, is otherwise physically and psychologically healthy. The patients typically tried other safer interventions prior to testosterone, including, vaginal estrogen to help with pain, relationship interventions, adjustments of antidepressant medication when indicated. They recommend at least one visit with a sex therapist prior, as it's safe and effective, and it may make pharmacologic therapy either unnecessary or enhance the response to treatment. And testosterone levels, again, shouldn't be used in determining whether there's an etiology of a problem. So how we do it here is there's an order set for testosterone. It includes a progress note, baseline labs, serial labs, follow-up visit intentions, a consent form that you can verbally do. It is a controlled substance, so you have to be the sole provider. And it's 1/10 of the male dose. We usually use it on the back of the calf. How you measure at 1/10 is really challenging because it's pretty goopy and drippy. The Ishwish experts talked about the baking spoon. If you're a baker, smidge. The smidge measurement is exactly the right dose. We say a dime size. I have a patient who is a researcher, and she's got it down to pipetting. So if anyone's interested in various creative ways to get the right dose, let me know, and I'm happy to share those with you. And then again, etiology of HSDD, here are the pro-sex and here are the inhibitors just kind of all put together. I'm just going to whip through a couple more things if that's okay. I'll talk a little bit about female orgasmic disorder, just because I think there's some things that are exciting about it. So an orgasm is a sensation of intense pleasure, creating pelvic muscle contractions, muscle tone changes, and induces well-being and contentment. The requirements include arousal, physical stimulation, adequate blood flow, and an intact neurologic system. There are two pathways for orgasm. The primary pathway through which the majority of women will experience orgasm is through the clitoris. So it's clitoral stimulation to the spinal cord to the brain. There's a secondary pathway. This is the minority pathway. This is a fewer percentage of women can achieve orgasm through the vagina and the cervix via the vagus nerves. This is people who can have orgasms through penetrative sex alone without clitoral stimulation. And this is where a lot of lack of well-being and poor self-image regarding sex. I've had patients hysterical that they're not having orgasms from penetrative sex alone, and wanting to know what's wrong with them. So this is a source of frustration for a lot of women based on how orgasms are represented in everything since the dawn of time. So orgasmic disorder includes delay in and frequency of absence of or markedly reduced intensity of orgasm. It can be primary, meaning you've never had orgasms, or secondary, meaning you used to have normal orgasms and now you're not. If you're not having orgasms and you don't care, that is not dysfunction. And there's a lot of people out there are fine with not having orgasms. These people typically will have normal levels of sexual desire. Again, primarily is going to involve clitoral stimulation. So talking about vasculopathy, neuropathy, that's, I had a patient, medications that change things as well. So diabetes, hypertension, nerve damage, alcohol, opioids, SSRIs, amphetamines, cannabis, inadequate stimulation, partner skill can be situational. You may have orgasms with one partner or with self-stimulation, but not with another partner. History of abuse, anxiety, depression, relationship, religious, others, downstream effect of other sexual dysfunction disorders. Treatment is going to be primarily cognitive, behavioral, directed masturbation is how this is generally treated. This is an aha slide that I always want to talk about. There are two types of nerve fibers in the clitoris. There are type A fibers that are thick, so they're going to age, they're strong, they're going to age slower. There are type C fibers that are thinner and going to age quicker. The fibers that age the quickest respond to light touch and warmth. The longevity nerves respond to vibration. So if you have a patient who's not getting aroused or having orgasms, they should try vibrators. Low frequency bullet vibrators can help people achieve orgasm every time, or usually in 86% of a small study. Little data regarding topical testosterone, more data about other local vasodilators coming, some promising surveys around topical cannabis and sex therapy can be useful. There's Dr. Lauren Stryker she's a really entertaining speaker. She has a podcast called Inside Information, if people are interested. Genital pelvic pain and penetration disorder. I don't know if you guys need to hear about that, but that's something that we are happy to treat in gynecology. I have lots of information about that if people are interested. GSM, genital urinary syndrome of menopause, all menopausal women who have symptoms of frequency, urgency, recurrent bladder infections, dryness, walking around dryness versus sexual dryness, please offer them vaginal local estrogen, and they can stay on it forever as long as they have no contraindications. And there really are no contraindications other than breast cancer. Breast cancer is not necessarily a contraindication. It is a precaution. In my entire career of doing this, I've had an oncologist on a single occasion tell me he did not want his patient on topical estrogen because he didn't want her to see a single molecule of estrogen. That is the only time in my 25 years of doing this. One cue is if you're going to use the cream, this is the instructions I give to my patient. Take the applicator, throw it in the garbage. Use the tip of the finger, and apply to the opening like that. Push the rest in with your finger, wipe it off on the vaginal wall. If you put the applicator up inside the vagina, you get a glob that then falls out the next day and has missed the vestibule. So please, if you prescribe this, please make sure you prescribe it to be applied to the vestibule, because that's where you want that elasticity of the tissue. Substance medication induced function. I'm just going to show you guys this slide because I think it might be important. These are common medications that you probably prescribe on the regular and how they might affect desire, arousal, orgasm. I had a patient come in with sudden anorgasmia and she had just started gabapentin. So that was interesting for us. And then life events impacting sexual dysfunction, pregnancy, sleep disruption, infertility, menopause, partner issues. And then finally, I wanted to talk about sensate focus for a second. This is an exercise that sex therapists run through with their patients, almost like homework, where partners show each other where they want to be touched, and partners show each other where they want to touch them. And it's very, very effective for kind of doing a sexual reset, and especially effective for people with pain. So that is kind of the talk. There are resources. I talk about the sex therapist resource, which is asect.org. Healthcare providers like us, books and articles can happy to share. If anybody's got resources, please share them with me and with each other. Local shops, we are fortunate that we live in Portland and we have not one but two Shebop shops that are incredibly well appointed, very female friendly. They have classes that sell out, navigating threesomes, foreplay, etc. Very sex positive, and that's it. So I did skip a bunch, but I think you guys probably know a lot of the other things that I would have talked about. And go to the chat.
Thank you so much, Joy. I think we're saving questions kind of for the end here, but I have a few to start with. One is, do you have any more specific lists of like sex therapists in the area or people that you recommend?
I mean, I think anyone that's going to be certified by ASECT is going to be fine. We have a one of our former women's health social workers, Heather Renfro, left us to become a full-time sex therapist. So, and I have heard amazing things about her from patients. But I think anyone that's approved by the board, certifying board, would be fine. Yeah, I don't think you need to tell someone a specific person to go to, but yeah. And very few go. It's kind of like when we refer people to PT, they just don't, like, I don't know why. I have a patient who's had pain and trouble and issues for 10 years, but she doesn't want to spend the money. I'm like, this is 10 years of your marriage. It's $200 a session. If you need 5, it's 10 years of your relationship. So it's hard. It's hard. I wish it
would
was
put in
covered. Yeah.
I know. I'd put in a plug for this smart set as well, which is super helpful in terms of like reminding you what labs you need to do and kind of when to time them. And there had been a rule or like a guideline on the testosterone prescribing that it was just for OB/GYN use, but we changed that now to include primary care too, so we can all prescribe. Do patients have to pay out of pocket for it, or do you know about cost?
I don't think it's very expensive.
Okay.
The sex therapy stuff isn't really, I think, covered in terms of but I don't think I haven't heard people talking about it. I think the Addy and the flibanserin and the bremelanotide may be different. I would also say if you notice anything in the smart set that doesn't make sense or seems inconsistent, please let us know. Part of it was co-opted from the Northern California smart set, and some of theirs, I think their testosterone goes up to 70 as therapeutic, and that's not consistent with the ISHWISH and Endocrine Society. So just if you see anything that's not consistent, please let me know.
Another question I had is whether you would be more willing to prescribe testosterone to a perimenopausal person, like with a IUD in place.
Like I said, perimenopausal, everybody says postmenopausal, up to date says peri or post. The most important thing is that there's no risk of pregnancy. So if they have an IUD and they're perimenopausal and they felt like this is something they needed, again, there's very few patients that I think I really consider testosterone. I've ordered it a handful of times, and the majority of them stopped using it. I have one patient that it's working great for, and she is 100% off label. She is a young patient with breast cancer who's on an aromatase inhibitor, and she's doing great on it, and she's the exception for many reasons.
A question saying, what is the smart set called? See, I think I had typed in.
I think it's HSDD. I think it's HSDD, hypoactive sexual desire disorder.
Sounds good. How about other questions? I know we just have a couple minutes. Feel free to actually ask or put them in the chat.
Testosterone should get you there. Nice, Kyla.
A few different
nice
meanings.
I like it. Yes. Lots of fun with this topic.
I have a question that I put in earlier. Is there a list, or are there plentiful enough sex therapists in this area that people can literally just Google sex therapist and not have a problem?
Do not Google sex therapist. You want to look on the AASECT website. AASECT.org.
So I would tell the patient to look at that website then to locate someone. Because that's one thing I was like, I mentioned it, and then they're like, well, how do I find it? I'm like,
there's AASECT.
Okay.
AASECT. Yep. Or if you forget, ask me. But yeah, the certifying board there's a lot of people probably touting themselves as sex therapists out there, and that's not what we want. All right, well then people probably have to run to the restroom before they start their afternoon.
Well, thank you so much. Really appreciate it.
And I have stuff on painful sex. I have a lot of resources. I've got dilators, lidocaine, lubricants. I didn't really talk about lubricants, which are really everybody should be using. It's not even if they enhance pleasure and ease of orgasm. So even if someone's not having dysfunction, lubricants are really helpful. So yeah, if anybody has specific questions or you want me to do more parts of the, address a painful dyspareunia talk, I'm happy to do that as well.
Sounds great.
All right.
All right.
Thanks
Have
for
a good
listening,
afternoon, everybody. Thanks
Bye.
again.